Martin, thank you and welcome to Northland District Health Board. We are a district health board, which means we're much bigger than just this hospital. We're a whole health system ourselves. And I know that you know, because I sent you quite a lot of information about Northland, that we have really quite different challenges to where you were over the last few days. In fact, the opposite. They advertise they have the best health in the country. We try not to advertise, but we actually have, unfortunately, some of the worst health status. But we also have we don't have enough money, okay, but we don't have a terrible health system, in that it's quite enabling for change and some opportunities. So I'm really looking forward to hearing what you've got to say. Always willing to take advice. We've got a great bunch of staff, really have a fantastic team, and thank you all for coming. I know some of you come on your days off, and of course it's school holidays at the moment, which is another challenge because many of us have families, but it's really exciting, and I'm looking forward to hearing what you've got to say. Thank you.
Thank you. You're welcome.
Thank you. So tēnā koutou katau, and of course I'd also like to acknowledge the traditional custodians of the land in which we're meeting tonight. Thank you very much indeed for that. It's great to be back in New Zealand. First time I've been this far north. When I've been in the past, it's been in Auckland, Wellington, Christchurch and so on. And it was fascinating driving up here, beautiful scenery. And of course, I'm very much aware of your challenges, although as you say, there are huge differences. I was in Devonport at the weekend having dinner with friends, and they've now got smoking rates in Devonport down to 7%. So it does show you what can happen. So what I'm going to do is I'm going to talk about one of the biggest challenges facing our healthcare systems. Your healthcare system, our healthcare system, everybody's healthcare systems. And in this slide here, this is the World Economic Forum. And this is a representation of existential threats to the world. Things that can go terribly, terribly wrong for all of us. And it's got all sorts of things like rising greenhouse gas emissions, water supply crises, earthquakes, volcanoes, all sorts of things like that. Somewhere in the middle of that, rising rates of chronic disease. So if you really want to grab the attention of politicians like John Key and others, I think you show a graph like that and say, look, there are all sorts of challenges that New Zealand, that the rest of the world face, but rising levels of chronic disease are one of them, and we need to have a health system that can respond in some way or other to that. So and what we have here is the likelihood that something will occur down at the bottom and the impact if it does occur up here. So there are some things that have a high impact if they happen, but they're very unlikely to happen, like the North Island being hit by an asteroid, for example. And there are other things that are very likely to happen sometime, like a pandemic. But there's a scatter, but chronic disease is right in the middle of that. Just a simple reminder, the world changed in 1921. The world changed fundamentally because in Canada, Banting and Best discovered insulin. And before that, kids with type 1 diabetes died in about 18 months. So essentially, you had the same situation with HIV/AIDS in Africa without antiretrovirals. Children would waste away, and within 18 months, they would be dead. And in fact, in parts of Africa at the minute, kids with diabetes waste away and die within 18 months, and people can't actually distinguish it from HIV, except by looking at the trail of urine in the ground and the ants following it because of the sugar. So that was what happened then, and the introduction of insulin changed what was a relatively short life expectancy into a condition where people now with type 1 diabetes can, in the countries that provide the best possible care, i.e. not the United States, but in other countries can actually have remarkably good outcomes and live a perfectly normal life. And then, as we know, 1950s, the development of diuretics and beta blockers and all sorts of other things. So we took all these conditions that in the past were untreatable, and even I can remember malignant hypertension, some of the things that were happening in the 1980s. That's really changed because we've got all of these conditions that people get in middle age, and they now take tablets, and those conditions are controlled, and they lead a relatively normal life. On the other hand, there are issues around managing that because as they live longer, they get more of these conditions. And you've got to deal with the multimorbidity, you've got to deal with the fact that the renal have gone off a bit, or their liver function, or they may be a bit demented and they forget to take their tablets. So it all becomes much more complicated. So just a reminder, we're talking about the challenges of chronic illness, lengthy and indefinite course of disease, multiple causes that can change over time. The diagnosis is often uncertain. No cure. This is a condition that you continue to have it. Lots of uncertainty, and that's a real challenge here. It's the uncertainty which is the real problem that we need to deal with. But linked to that, unlike, say, getting an acute appendicitis, if you get inflammation of your appendix tonight, what you will not do generally is go to the internet, go to the library and research it. You'll go to the emergency department and hopefully have your appendix removed. On the other hand, if you've got a chronic condition, you've got all the time in the world to find out about it. So you'll go to the internet and hopefully you'll find some sensible information. Sometimes, of course, you don't. But the key point is that with an acute disease, the professionals are knowledgeable and the patients are inexperienced. With a chronic disease, there's much more of a balance. And I know this is all incredibly obvious, but it's helpful, I think, just to refresh our memories before we go back into the rest of the talk to see how we deal with this. The requirements for chronic illness care are different from acute again, enhancing functional status, minimising distressing symptoms, prolonging life through secondary prevention, enhancing quality of life. It's a complex response, and that word complex, we'll come back to that again and again and again. Complexity. That's what really characterises these conditions over an extended period of time, coordinated inputs from a wide range of professionals. Now, I'm quite sure that up here you have no problem in coordinating everybody, and they all come together and work as a whole. Unfortunately, that doesn't happen everywhere, and we all know the analogy, and I am a physician myself, of managing doctors being like herding cats. You know, it's quite difficult at times to try to get everybody to pull together. You need access to essential medicines, not so much an issue here, but it is in many countries. Huge challenge. And in fact, I was talking with Dale Bramley the other day. We were talking about work that we're doing, looking at combination therapy for hypertension, for example, and particularly in low resource settings, and promotion of active patient engagement. All dead easy so far. It's a challenge. But the key question is not, we've got lots of challenges, there are lots of things that happen. Can we do anything about it? Does it actually make a difference? Well, this is from a systematic review which looked at different aspects of care coordination to see if they made a difference. And what it did was to say, we've got all of these models of chronic care responses. Lots of different packages, they're labelled in different ways, but if you start to distill them out, you find that there's a number of core elements in them. So there are some that involve changed relationships between service providers, like multidisciplinary teams and integrated case management and so on. There's a group of things that fit in there. There's types of coordination of clinical activities, joint consultations, shared assessments. Two different, a nephrologist and a cardiologist and an endocrinologist come together to see what's happening with the patient. Improving communication between service providers like case conferences, reminder systems and other forms of support for clinicians, information systems and support for health and social care workers. So that was a taxonomy that the authors of this report produced. And what did they find? They found that actually in many cases, many of these things, about 2/3 of the time, they worked in terms of improving people's health. There was some improvement in health. It may be improvement in risk factors. It may be improvement in verifiable health. But there was something that was good that was happening in about 2/3 of cases. But in about 1/3 of cases, it didn't. So some worked, some didn't. And they were hugely different. What did they find in terms of cost saving? Much less evidence there. So these things do cost money. They often improve health, but you don't do them because you want to save costs. And you have to be very clear on that. Often these things will be more expensive, but they will, if they work, give you a better outcome. And unfortunately, people often say, well, the real reason for doing this is to save costs. This was another example a little bit earlier. It was looking at outcomes of integrated care programs, but the key point there was that it was showing that there's lots of evidence about functional status and health outcomes, much, much less evidence on cost, but it's a similar sort of study, and we see that. What about the economic focus? Let's focus particularly on the economic aspects. I've already said the evidence isn't great, and we can see this confirmed in work done by my colleague Ellen Nolte. And this was a review of reviews, and a big problem we have here, because we know that we need different responses for chronic disease management. But what is the intervention? What is the package? It's not that you go along to IKEA and you say, I want a chronic disease management package. It doesn't happen that way. So there are different bits that are put together in different ways. And the real challenge is trying to learn lessons because nothing is comparable. The words are different. The skill levels are different. The skills that a nurse has are very different in different health systems. The responsibilities they have, the roles that they play, the forms of communication, the patient expectations, all sorts of things are difficult. So none of these studies, although they essentially did look at integrated care, you looked at this and said, well, actually that's a sort of model of integrated care, but they were called things like case management, care coordination, collaborative care, disease management, and so on and so forth. And as if that wasn't bad enough that we can't even categorize and be clear about defining what it is we're measuring, the even bigger problem are the methodological variation in the studies. So in terms of how you measure the costs, which costs you include, do you look at it from the patient's perspective, the health system perspective, from the societal perspective, trying to compare any of this, it's like chalk and cheese, apples and pears, swings and roundabouts, in any metaphor you can think of. Relatively small number of studies, some evidence of cost effectiveness, but difficult to interpret. So that's one of the challenges that we face, in that we really don't know what it is we're talking about. We get people, and this is the danger in all of this, because of course the danger of inviting people from outside your country is that they are often coming to sell you things. I have no financial interest in anything that I'll be talking about tonight, but of course there are people who've done something in some part of the world and will say, if you only do this in New Zealand, or in this part of New Zealand, you'll get miraculous results. Well, you may or may not, but you need to think very carefully about the context. So what we've shown so far is there is evidence that these things can get better results. So they can work. They don't always work. They can save money. They don't always, and often they don't save money. Is there a need to do something more? Well, there is, and this is the Commonwealth Fund data, which looks at care coordination. It asks patients with chronic disease, how are you being looked after? And actually, New Zealand doesn't do too badly in this. In many countries, people are reporting they've got real problems with coordination of their care, gaps in discharge planning. Okay, New Zealand could be doing a little bit better. The UK does actually very well on this, and it always has done. It gets very good results on things like the outcomes of diabetes. If you look at the Dairy and the British Diabetes Association studies, the cohort studies, really excellent results. And in other countries like France, for example, social insurance systems, it tends to be more difficult. Support for patient engagement in healthcare management, whether or not patients are contacted to see how things are going. New Zealand's somewhere in the middle. So actually New Zealand does pretty well in these things. It's not as if you've got huge problems. I mean, you may have issues around inequalities in health, I fully accept that. But in terms of the way the health system is performing, it actually, in this area, does quite well. When we look at coordination, of course, coordination can take place at different levels, and we need to try to think about where it is we're intervening. And if you're an individual clinician, you will want to do something at your own level with your colleagues. If you're running a DHB, you'll want to be doing something within the DHB. If you're sitting down in Wellington and you're trying to organise the whole health system for New Zealand, you'll be working at a different level, at a system level. So when we look at these things, we look at the system level, an organisation or network, taking full fiscal clinical responsibility for a defined population. The ones we often talk about are the American models, Kaiser, the Veterans Administration. Or it can be organisational, which would be like what you might have here. But of course, there are bits that don't fit into the organisation here, like primary care. There are challenges on that particular interface. Coordinated set of services for conditions with particular conditions. We'll come back to that in a minute. Or you can coordinate it at an individual level. You don't need to wait for the chief executive to do something. You don't need to wait for your new health minister to do something. You can actually just coordinate by getting together with your colleagues from different professional backgrounds or different disciplines and do things. All of these are possible, and they're all aspects of integration and coordination of care. We can look at the different models, and this is maybe a helpful model to think about where you are and where you want to be, because you can be right down at the end of full segregation where you simply have a referral mechanism. And it's nothing more than a patient with chronic disease comes into a general practitioner's surgery and you refer them to one person, you refer them to another, and you refer them all over the place. And they may get better because they're doing so much walking around, visiting all the different specialties. That may be therapeutic in its own right, but it's not really ideal. There are better ways of managing, or you can go right up to the end, network managers, pooled resources. And it's helpful to think about where you are on that spectrum. But you don't always need to be up at the top end of the spectrum because, of course, different patients have got different needs. And if you have somebody who has got simple, straightforward type 1 diabetes and they're managing it perfectly well on their own, you do not need to put in a massive coordinated care process for them, because actually you probably don't need to do anything at all for them because they're basically looking after themselves. They'll need their eyes looked at, they'll need some their fundus photography once a year or whatever, they'll need some things checked up, their HbA1c and so on, but they don't need an entire coordination mechanism for that. On the other hand, if you think of, and one of our unfortunately now late friends, I was a nurse with my wife, who died at the age of 49, who had diabetes. She, before she died, had a hemiplegia. She had one leg amputated. She had 2 renal transplants, the second one being a combined renal and pancreatic transplant. She had retinopathy and was virtually blind. She had neuropathy, of course. So for somebody like that, the process of coordinating her care is more akin to organising the D-Day landings. You know, that is a huge effort to get all of that together. And although she was very well informed, she was a cardiology ward sister, and so a very informed patient, but really challenging. So for her, she was sort of up there at the top, needed a high level of integration, a high level of user need, multidisciplinary teams, because of course if you're having renal and pancreatic transplants, of course there's going to be multidisciplinary teams, but there may be people who need to be further up there, but there may be people who are actually perfectly all right without all of that. So we need to make sure that we don't just throw everything at everybody regardless. These should be tailored to patient need. What I'm going to talk to you about is a study that was done in our team, the DISMAVAL project, and it looked at chronic disease management across Europe. It was a review of approaches and models that were in place in 13 countries. Some of them were social health insurance systems, some of them were tax-based systems, and it used the chronic care model as an organising principle. And I guess many of you are familiar, people all familiar with the chronic care model? Ed Wagner's work from Seattle. And interestingly, much described in the literature, rarely evaluated. And there's very little evidence about whether it, how much good it does and so on. There's a real paucity of evidence. And what evidence there is essentially with people who only have diabetes. And that's one of the things we'll come back to in a minute. But all the same, regardless of whether or not it actually works or not, it's a good way of thinking about things. So it's helpful to have a checklist to say we need to have some element of the community involvement. We need resources. We need appropriate policies that are supportive. And it may be just policies on transport and policies on housing and things like that, which actually help people to lead a normal life. But then we have a whole lot of things within the healthcare system, support for self-management, delivery system design, so that people are actually not going to all over the place for whenever they could have all the services together. Decision support, reminders, using IT, clinical information systems. Clinical information systems, the real challenge, and I don't need to tell you that, everybody knows that clinical information systems are a problem. And we need them now because things are so much more complex. My parents were general practitioners, and they had no clinical information system except one, and it was in my father's head, because not only did he know all his patients, he knew all their families, he'd often delivered them, and so on and so forth. And there wasn't that much information to hold about them anyway, because there were only a few drugs available, so it wasn't that difficult. And he was on call all the time. He didn't take holidays, worked every night, and so on and so forth. Now, that's not the same anymore, so you do need some mechanism for keeping that information other than in one person's head. But very, very difficult. And if you get it all right, you get an informed, activated patient in theory and a prepared, proactive practice team, and you should get better health outcomes. Now, that's the theory. And I'm simply putting that up not to say that if you do all of this, you'll get fantastic results, because we don't actually have the evidence on that. But I'm saying that it's a good way of thinking about things, so you've got some systematic framework. And I like frameworks and checklists and things like that, because I'm very simple, and it helps to have something I can put things onto and try to understand them. What do we find when we look at all these programs? Now, I'm not going to go through the programs in detail, but here are just a few examples. The Sophia Diabetes Care program from France, the Regional Disease Management programs from Denmark, the German Disease Management programs. I guess you've already heard other people come here and talk about some of these, particularly the Dutch ones, the bundled payment contracts, or the disease management programs in Germany. A lot has been written about them by colleagues like Reinhard Busse and others. But the key point about all of these is the ones that are written up, the ones that are rarely evaluated but often described, is that they deal with a single condition. Diabetes, or there may be a program for COPD, the diabetes management programs in Germany, type 1 diabetes, a different program for type 2 diabetes, a different program for ischemic heart disease, a different program for heart failure, and you enroll in these. So when you enroll in them, you opt out of the standard fee-for-service social insurance system. Your doctor is paid more than they would do, there's a financial incentive, and then they're responsible for all aspects. And if they need to see you every day, they have to see you every day. They get no more money for it, whereas in the typical social insurance system, every time if they saw you every day, you'd be clicking up a payment for every visit. So they've changed it completely. That's fine if you've got type 1 diabetes and nothing else. What do you do if you've got type 1 diabetes, ischemic heart disease, asthma, and you say, well, which program do I enroll in? You can't enroll in all of them. Where do you go? That's the real challenge with lots of these things. So it's great having a program on COPD, provided you don't have something else. And that's the real difficulty with doing all of these things. What are they trying to do? What are the aims of these programs? Well, the Austrian one, improve quality of life, place patients at the centre, reduce hospitalisation. Now, what we're now going to do for the next few minutes is, and I should have distributed the cards earlier, because we're going to do a chronic disease bingo. And you're going to look at all of these descriptions, and you're going to tick off the words that I use, and whoever gets all of the words on your card first, like improve quality of life, patient-centred care. These are the words that we'll see all the way through, interdisciplinary, intersectoral, coordinated. So in a way, there's an element in which you can design a disease management program by putting all the words into a random organizer and getting them all out and putting them together in some way or other. Improve coordination. Here we have quality again. Where are we going to? Coordination, coordinated treatment, care across providers, multidisciplinary cooperation, detection, treatment, rehabilitation, and so on. So lots written about these things, lots described, but what do they actually achieve in practice? Difficult to know, but the problem that we really face is they're often dealing with one condition. The other thing that we find from looking at the international experience is that there's a growing trend to make much more use of nurses in chronic disease management. Many nurses in the room, by the way, can I just... Okay, good, a few, good. Where are all the rest? Where are your colleagues? And so we see that fundamental principle with health systems and why you need to be careful about taking ideas from elsewhere. Any complex system is characterized by path dependency. The starting conditions are very important. You cannot take a model that was developed in a completely different system and just plonk it down in another one and think that it's going to work. So for example, if I was in New Zealand, if I was working here, I might say to myself, well, your system of paying general practitioners may not actually be the ideal way of doing it, and the gatekeeper rule may be problematic, and so on. I can say that, but try changing it. I know many people have tried to change it, but it's incredibly difficult to do. So you've got path dependency, and you have that in many systems. So if you take a country where multidisciplinary team working was always happening, then it's dead easy. There's a tradition, there's a belief, there's a culture that people work together. If, on the other hand, where most primary care is provided by doctors working in solo practices on their own, without nursing support, without support from other clinical groups, then it's very difficult, particularly where the funding system makes it difficult where they're paid fee for service. Fee for service is a real problem with trying to bring about these changes because people don't want to split the fees. You need to look at the financial system. So it also may be difficult in a country like France. The legal system may be important because in France you've got a codified Napoleonic legal system where everything is written down in immense detail. And if you want to get nurses to do something more, then you've got to go back and change the primary legislation. It has to actually go through the National Assembly. We also see when we look at these programs, there's a tendency to try to reduce barriers among sectors, but much less common. Often they focus on things like the coordination and so on, but in reality, the attempts to really break down the barriers and get out of the silos are rather rarer. When we do see them, what we find is that often they're about improving communication across one of the interfaces, primary to secondary care to rehabilitation. That tends to be the most common that we see, rather than more holistic, bringing everybody together. It's often just trying to bridge that gap at the interface. The real challenge we have is often that they're implemented as pilot projects and they never get beyond the pilot project stage. And they're often only in one part of a country. So they've been one part. And when we've looked at this in a little bit more detail, and this is not scientific, but it's an impression that Ellen and I have, is that they tend to be more easy to do in places where everybody wants to live, where health professionals want to live. Now, I don't want to be as cynical as Ivan Illich, who said that doctors congregate in areas where the weather is good and the patients are healthy, like Florida. But there is certainly an element. So you get people coming from England, from Torbay in the south and the English Riviera, where it's actually remarkably easy to get health professionals to come and live there because you've got palm trees along the front and you've got beautiful weather, a microclimate, the schools are good, the houses are nice. It's just generally nice. You never, in our experience, see these things in the deindustrialized cities of northern England. You never see them in the deindustrialized places like in Poland or places like that. It's much more difficult to do that there. And that, I think, needs to be recognized. These things are much more difficult if you have a problem recruiting and retaining staff. You cannot do these things in inner London, for example, because we have such a high turnover of staff. Nobody is there for that long to have the continuity. And these things really do seem to require individuals to be in post for a long period of time. Now, in some healthcare systems, and many of you are very familiar with the system in England, God help us, where a chief executive has a typical life expectancy, job expectancy. Dale was telling me the other day of 22 months it is at the minute, which is better than an infantry soldier in the First World War. I know we're talking about that at the minute, but it's not much. And the few places where we do get good processes are the ones where the chief executives have been there for a very long time. So if you've got a good chief executive, keep them. Don't get rid of them, because it's not like football. Well, actually, we can look at the football teams and get rid of managers. That doesn't work either. But the continuity is terribly important, I think. That's one of the things that's not really been systematically evaluated, but it's very much an impression you get from the experience of looking at these. Often these things need money. They need financial incentives, so they need startup funding. And the funding, how you put the money into the system depends on the system. It depends who has the power to make the change. Is it the payer? Is it the provider? And that will be different in different countries. So in Denmark, for example, it was the municipalities that had the power. The funders, the primary care trusts in England, had the power to make things happen. Whereas in France, it was much more about building provider networks and getting the providers to work together, giving them startup funding for the IT systems, for the meetings, for the coordination, and so on. There may also be financial incentives for the ongoing running of the program, because often these things do cost a little bit more money, and you've got to find a mechanism for doing that. You can incentivize payers, again, by giving bonuses. You can give prizes, for example, have a system of awarding prizes to the DHB that does the most innovative thing, something like that. That would be a possibility. Or you can incentivize providers by saying that we will actually pay you a bit more for doing this, but in fact, it will maybe lead to changes in the way you move away from fee-for-service or something like that. Or you can actually incentivize patients, because particularly in countries where there's a large co-payment element, you can say that your co-payment will be reduced if you sign up for one of these programs. That's another way of doing it. So there are lots of ways of doing it. I think the message is it depends on the health system, and you can't simply translate these from one place to another. The other thing that we find is, I've already said a bit about this, but the levels of patient and clinician support vary. And particularly, as I've said, you find that these are much easier to do where you've got a high level of continuity. The majority of these schemes do provide some form of support for patient self-management, but that's often poorly developed. There's still a long way to go in doing that. And the one thing that seems to be difficult everywhere is getting the IT systems to work. Everybody seems to have problems with that. It just seems to be incredibly difficult. Now, this is not unique to health, because as we know, we in England have had multi-billion-pound failures in the welfare system, in the criminal justice system, in defence procurement, and basically everything. And it's not just government, it's not just the public sector. The private sector do it too. Look at the financial markets and look at some of the things that happen there. They don't work either, except they don't talk about them quite so much. So getting the IT right is really a real serious technical challenge. What do people say about these things? Well, when we ask them what they think, the continuing institutional divide in many countries is really challenging. In France, it's not yet in our habits to consider that chronic disease is a public health problem, a question of medical culture. In France, the medical or health culture is more concerned with acute care than prevention. The health authority has organised a lot of information and their communication campaigns, but communication is not prevention. In Austria, the risk minimisation considered as less important, perhaps not in theory, but certainly when it comes to providing financial means for these programmes. So people who are doing these things are hearing a rhetoric. They're hearing that they're being told they must do this. They know themselves that they must do that, but often they find that the health system keeps coming back to the acute care bit. It's a bit like the issue if you're in public health, where things keep coming back to the individual level rather than the population-based measures that are much more effective. Even in a country like the Netherlands. Netherlands is an interesting country. Anybody Dutch here, by the way? I know that there are. I was actually reading Angela's brother's book on the history of New Zealand, and he was talking about how, of course, there is a long Dutch tradition in New Zealand in that the first form of, as he said in the book, and forgive me for this, the first form of imported food was actually a dead Dutchman. But then he talked about how, having had that experience, they didn't come back for 300 years, but they did after that. So welcome back. And so the Netherlands is, of course, strange because, as you know, it has a social insurance system. And often getting these programs together in social insurance systems like France and Germany and so on is really, really difficult. But there's something particular about the Dutch social insurance system, isn't there? Which has many of the characteristics of the German social insurance system, because it was introduced in 1942, not necessarily with the consent of the Dutch population, because there were other things happening to their country at that time. Forgive me for the Germans among you here. And you actually had a social insurance system that was grafted on top of a model of primary care that looked much more like the British model of primary care. In some ways. You did have multidisciplinary teams. You had strong primary care that you didn't have in the much more specialist-based systems in Germany and France. And that again shows you how even in systems that look the same on paper, and the recent reforms in the Dutch system, the system up until about 15 years ago, looked very like the German model, because in fact it was essentially the German model. There were subtle differences. But even so, even though on paper it looked the same, the operations were very, very different. And this highlights the importance of context. Caregivers working autonomously have their own ways of working, not connected. So many things are happening twice, or things are not happening at all, and there's no real coordination. A lot of patients are feeling very, very lonely, especially if they've got more than one disease. But there are, even in places where there are good practice, the Basque region, Rafael Bengoa's work in the Basque region developing integrated chronic care. Interesting, talk to different people. Rafael's a very good friend, so he tells me it's all working wonderfully. One of our students did an evaluation of it and said, well, it wasn't quite as good as that. But, people have different impressions when they look at things. But even there, the gap between primary care and specialised care is a key barrier. It's a real challenge. And you have the misalignment. So you've got to get the alignment of incentives right. If you're paying people a fee-for-service model, for example, then you're not going to get people to be interested in joined-up care. What's the reason for doing it? All you're doing is cutting your income. A lesson for primary care here, of course. It doesn't pay working together, and it doesn't pay self-management of patients. So you need to have that mechanism. And this is the problem in a number of countries where governments are looking at activity-based financing and things like that, paying you to do more, getting you to do more for the patients, whenever you really want the patients to look after themselves, ideally. That would be the thing you want. But then if that happens, then the healthcare system is told that it's being less efficient because the productivity is going down because they're actually doing fewer things on people. And this is a real problem of public goods, and it's more about the prevention element. And this is where I think you've got so many advantages in New Zealand. You've got geographically defined populations in a district health board. It's fantastic that you've got that. We did have in England, up until the recent disaster that we call the Health and Social Care Act, now there are no fixed geographical boundaries. Clinical commissioning groups can be responsible for people anywhere. In fact, it hasn't changed that much because there's a large amount of inertia in the system. But at least you know that you're in charge. You may not like it, but you are in charge. You've got a geographical population, and you've got, if you invest in the health promotion of your population, and which of course needs to be done, that will benefit your hospital. That will benefit the healthcare system around here. But if you've got a competing insurance scheme like in Germany, what is the reason why the AOK or the BKK or one of the sickness funds, why should they invest in broader health promotion measures, reduction bans in smoking in public places or changes like that that have an effect for the whole population? Why should they even invest in better health and personalised measures for their patients? Because they'll go off and change their health insurer and somebody else will benefit from it. So you can see the very strong argument for doing what you do here, which is having a population-based thing. I know there's no plan to change it here, thank God, but then we didn't think that anybody would be crazy enough to do that in England either. And then the problem of political priorities and political will. This is a shock for many people, but there are sometimes cases when politicians say one thing and they mean another. I'm sure it doesn't happen here. But this issue, if you have to focus on acute care because that is what is selling votes, getting chronic disease management to be a high political priority is really difficult. Politicians love opening hospitals. And they love opening facilities, concrete things that you can touch, things that you can cut a ribbon on. But of course, you can't really do that in many of the things that we're talking about here. So inevitably, you get a lower priority. And if politicians are going to say that something is a priority, they need to mean it. Say, here's the money, because we're putting our money where our mouth is. We're actually saying, we say it's a priority, and here is the money to make it a priority, because often it's not, as in France. The law says that patient education is mandatory. However, where the financing comes from is not clear. I've been away from the UK for a few days, and of course we're having an election at the minute, and where the money coming from any of the things that the current government is promising is a complete mystery. It's absolutely fascinating. Another 8 or 10 billion pounds committed every day, it seems, when you listen to the news. I can't really quite keep up with it. So that's what we find when we look at all of these things. We're finding that often these programs are looking at a single disease. They're not looking at multimorbidity. Often we're seeing that there's an enhanced role for nurses, which is great, but it's easier in some systems than in others. Often we're finding a misalignment of incentives, and the system isn't really being put in place. It's making it difficult because people want to do things that are good. And often we're seeing it's much easier to do things in places where you've got stability, where people hang around for a long time, where the doctors, where the nurses are around, where they know their patients, where you've got a chief executive who stays in place for a long time. That seems to make it much more easy. And I've been a bit negative about these things, but many of these programs actually do work. Remember, about 2/3 of them actually do improve people's health. Some of them do make cost savings. So let's not get carried away with the negatives. They can make a real difference, but it's not easy. It's challenging to do. What do we find? Improvements, often process measures like the rate of eye examinations and things like that. Evidence of outcomes are less certain. The real problem is we don't have good evaluations of this. Now, if I was introducing a new drug today, I would spend essentially $1 billion on doing it. I would spend a huge amount of time on phase 1, phase 2, phase 3 trials. I would have all the development, all the basic science, a massive amount to actually design the intervention, in this case, a tablet. So all of that work would be done. Then you do a randomized controlled trial. These things can be evaluated. We're doing an intervention at the minute where we're looking at improving management of hypertension in Colombia and Malaysia. And our idea is that if we can get a package which will be fixed dose combination therapy for hypertension with 2 or 3 different drugs, because often you need that to control hypertension. Really simplified guidelines, because in countries like that, you simply cannot say, come back from multiple attendances, so we check 1 or 2 weeks later and so on. It doesn't work that way. And we need to look at mid-level health workers, because there aren't enough doctors. So we've spent the first year of that project doing ethnographic, multi-method research to understand what the intervention actually needs to look like. And we find, for example, in Malaysia, where you've got the coming together of 3 traditions of Aboriginal Malay, traditional Chinese medicine and Ayurvedic medicine, all being mixed up, none of which actually have any concept of an asymptomatic condition that needs to be treated. And the word for disease in Malay is the same as the word for pain. So if you don't have dis-ease, if you feel all right, you don't need to take tablets. So the intervention has to address that. Not a problem in Colombia. The problems in Colombia are the supply chain for the pharmaceuticals. There are other issues there. So we need to do much more to try and contextualize this. And then, of course, we're doing a cluster randomized controlled trial, having done all of this work to actually design the intervention. Question is, of course, if they do benefit people, who do they benefit? The integrated care program in the UK, interestingly, staff were much more positive about new ways of working than patients. We also found that there were some things that worked better and some things that didn't work better. So the black is before and the grey is after. And we found that they found that the patients were saying, well, they're more likely to have a care plan. They're more likely to be clear in the follow-up. They're more likely to know who to contact with questions, but they're less likely to see the GP they prefer. The GPs are less likely to involve them in decisions about care, and the GPs are less likely to be listening to them. And that may well be because there's been a big investment in IT systems. And we all know the problem that patients complain that now you go to a GP, certainly in England, and the GP doesn't look at you, the GP looks at a screen, because they're filling in the clinical information system. Now, of course, there is a problem in that most health systems haven't discovered the concept of barcodes, but leaving that aside, you still have the effort going into the data entry rather than actually talking to and listening to the patients. And we also they also found in this study that it had different results. Increase in emergency admissions, but fewer elective admissions, fewer outpatient attendances. So some things got better, some things got worse. And of course, because some things got better and some things got worse, everybody interpreted it differently. And everybody you asked, they took a different message out of it. Was this a success? Well, there were some successes, and there were some things that weren't so successful. Was it an overall success or a failure? Well, you take your pick. Depends what you read. So what way to go with all of this? I think clearly we need to understand better the differential impacts of these new approaches and what works for whom, the needs and preferences of service users, and we need to tailor these to the individual circumstances. That's pretty clear. This is just a study looking at, which I think is quite interesting, going back to the Netherlands again, and it's looking at people who were involved in a diabetes management program and then followed up. Now, it needs a bit of explanation, but if we look over here in the first column, people who had an A1C of under 53, but basically this is good control. And if you've got blue, you're good control. In the beginning, in the initial one, if I showed you this graph at the beginning of the study, this would all be blue, this would all be brown, and this would all be green. And so if you move from blue to brown, you get worse. So what it was showing was that many of the people that were controlled, well controlled at the beginning, most of them were still controlled. I mean, they couldn't get any better. They were as good as it gets, but some of them did actually get a bit worse. Then if we look at the people who were not quite so well controlled, some got better, some got worse. Quite a few got better, about 35% or so got better. And what happened to the people who were really not controlled at all, who would have been green all the way through? Some actually were totally controlled, blue, really good, that's exactly what you wanted. Some were better controlled but not fully controlled, brown, but some were still green, so some were not controlled. The real gains there, the people who benefited most were essentially these people here. So the programme was most effective for the people who had the worst control to begin with, and it didn't really provide much benefit. And in fact, for some of the people who were already controlled, it may have actually made them worse, but that was probably a bit of random variation and regression to the mean and things like that going on. So again, this question of who do these things work for, we shouldn't assume that they necessarily are the same for everybody. The other message, I think, which is important is most of the existing research has focused on a few specific disease, and we really need to think about this issue of multimorbidity. Many of you will be familiar with this graph from the Lancet, Stuart Mercer's work, which essentially shows that if you look at people with chronic diseases, you get, by the time you get to 70 or 80, you're likely to have 4, 5, 6 maybe different conditions, all of which need managed. But the really important thing, and an important issue for a DHB like here, where you've got high levels of deprivation, is not only do you have more people with chronic diseases, but you have more people with multiple chronic diseases. And we see this in this slide. And essentially in the light grey, what we're seeing is the affluent regions. And so we've got coronary heart disease, diabetes, COPD, cancer. And these are the number of people, if we go up to the top, in an affluent area, people with coronary artery disease in an affluent area, 19% of them will also have diabetes. In a deprived area, 23% of them will also have diabetes. And there are some big changes there. People who've got painful conditions like arthritis and things like that. In a affluent area, 14% of those will have diabetes, 28% of them in a deprived area. Again, with COPD 15 and doubling the percentage. So in an area like here where you've got multiple deprivation, not only are you going to be having a problem with more people having chronic diseases, but more people are going to have more chronic diseases, and that really makes it a challenge for you. So the answer to that is, well, you could also all go and live in Devonport or somewhere like that, but it's not going to do much for the health of people around here. This is a challenge, and I think you just need to congratulate yourself for sticking at it, for doing all of this, because it is much more difficult. It will be much more difficult for you to do this than it will be in other parts of the country. We really do need to use existing evidence much better to understand the local context. And there is a real problem. I've gone through these fairly quickly. All of the information I'll show you at the end is easily available on our website. You can read up what the programs are. But for God's sake, don't take something that was invented in the south of England and think that it will necessarily apply here. There may be lessons to be learned. There may be good things about it. There may be ideas you can take away. But the idea that you can just plonk it down somewhere here is simply not going to work. What are the real things that we need to do? We need to provide a regulatory context that will enable innovation, incentive systems that encourage people to change, encourage innovation and don't act as barriers. And we need to be really careful about those changes that are going to fragment care, activity-based payment, competition. And what is amazing, I keep coming back to the UK because we've been so, or England, because in Scotland it actually works rather well, but because we've been so battered by all of this, if the government recognises that we have a real challenge with rising levels of chronic disease, the last thing you want to do is to fragment the health system. It's just insanity. And of course that's what they're doing. And we've got very good results up until now. We're already seeing life expectancy at age 75 and 85 has been going down for the last 2 years. Now that's really, really worrying because it should not be happening. Create a policy environment that gives you the means for those who are asked to implement change to have the capacity. Knowledge centres like this, well, I know you're moving to somewhere else in a minute, but shortly, but having training, having continuing professional development, not over-bureaucratising it, I think, but just making sure that people have access to acquiring the skills that they need and deliver consistent messages. Are we trying to improve care for people? Are we trying to cut costs? We need to be clear what it is we're doing, because if we really want to improve quality of care in many countries, you will need to spend a little bit more money, because most of our countries actually don't spend enough money on healthcare anyway. We need to have opportunities to learn from experience. I mean, that's what we're doing today. I suppose that's what you're doing by inviting me here. We need to make sure that we incorporate the patient perspective and to understand the situations in which people live, because many of the aspects, to go back to the chronic care model, many of the things that actually make it difficult for patients have nothing to do with the health system. You've got the gold card here, you know, transport for older people, bus passes in the UK. It is the gold card, is it?
Not any buses in those.
Okay, you've got, okay, well there you are, you've made a point. That's the point.
Well, sorry.
No, but fair enough, fair point. No, thank you for that. A good point. So what do you actually need to do to improve the lot of people with chronic diseases here? I mean, you need healthcare. I mean, all of you are doing a great job, and I'm delighted you're doing it. But somebody needs to be going out there and demonstrating on the streets to say we need a bus service. Because that actually will make it much, much easier for people to get to the facilities, to engage, to come together, to do all the things. That will probably make more difference to people's quality of life than many of the other things that we're doing. So we just need to recognise that. And if that is a problem here, that needs to be addressed somehow or other. And with that, I'll just say thank you very much indeed. We've written lots about this. Don't need to go through all the details that I throw up on the slides there, because nobody ever takes anything in on a lecture. The only reason for giving the lecture in the first place is to make you aware that there are things you can read at your leisure. And you can't really see it there, but that's Caring for People with Chronic Diseases that Ellen and I wrote. Managing Chronic Conditions, where Ellen, Cecile Kanai and myself wrote 8 case studies from different European countries, and another one that Ellen and Cecile and Richard Saltman led, which is looking at chronic disease management in different countries. And if you want to find them, hopefully you all know about the European Observatory. There's a wealth of information on it. Including a health system profile for New Zealand even. But we do things like, obviously, our summer school health system reviews, a Twitter feed, the Health Systems and Policy Monitor, Health and Financial Crisis, and a mass of studies on health workforce and pharmaceuticals, on cancer, on ageing, on anything you happen to want to know about. And with that, thank you all very much.